morning, everybody. We have an invisible Dr. Rosensweet right now. There he is.
And here I am.
Yes, we love this entrance. It's fabulous. Really, it just adds that extra punch. You know what I mean? Good morning.
Good morning.
It's nice to see you as always. And I'm hoping everybody and yourself had a great 3-day weekend. We did.
Yes. Love it.
Hey, I got to turn this up because I can't hear you. Okie dokie. So, you know what? I'm going to start off just with a nice compliment that came in from South Africa.
Wow.
Yeah, a woman named Darcy, and she said, I just want to thank you, Dr. Rosensweet, so much for your book, Happy Healthy Hormones. It's excellent and exactly what I needed, as so many of the doctors I've been to thus far have not been able to help me. But now, having read your book, I feel more empowered to know who to look for, what to ask, what to say as I make my way doing the doctor shopping. Aw, isn't that
Very
nice?
nice. Yes, I love to hear that that's helpful. I originally wrote that book for women, realizing that in these early times, the more a woman knew, the more she'd know what to look for and could be an active participant in her process. That was really important to us. And so myself and a couple of wonderful editors, Sherry, who you know.
I do indeed. First voice I ever heard. What a lovely woman. And many do hear her voice. She's fabulous. And she did a great editing job, I'll tell you that.
Yeah, and Shay Lindner was in on the original edits and did all, the two of us did those cartoons together.
Oh my God, it's so fun. The language is fun, the explanation's fun, and you do not ever miss a beat. So you get through that book, and at the end of the chapter, there you are saying, and I know what you're thinking. I love that. I was like, I'm so confused, but it's not that confusing. But you got that. You're like, are you confused yet? Yes. Okie dokie. So starting off, we have good questions as we always do. And I'm going to smack it to ya, or I guess sock it to ya. Number one, Dr. Rosensweet, Dr. David Rosensweet. What is your opinion on using a vaginal hormone cream for our hormones? You know, using hormones. How do you feel about using vaginal creams? There are a couple out there.
Well, there's benefits, there's advantages, and there's disadvantages. The vagina is an excellent absorptive surface.
Yeah.
So what's placed in the vagina is going to get absorbed into the body. It's a mucosal surface. They absorb better. And the one thing, there's a couple of things that I do not really think are optimal around intravaginal. And one is that if a woman's having intercourse, she wouldn't want to put estrogen in her vagina.
Right.
And then the most significant detriment to me is testing of a woman's hormone levels is so crucial to good medicine to really assure that there's not too much and not too little. And for those who believe that symptom alleviation is all that's needed and you don't need to test, or that other tests of any kind work other than the 24-hour urine hormone test, sorry to say, like in a study we did, 25% of the women who felt better, they thought they had landed at their optimal dose. 25% of them were on doses too robust, and they were at risk for breast glandular cell proliferation. I didn't say cancer, I said risk of breast glandular cell proliferation. We don't want to see that in a menopausal woman. That speaks to cell mitosis, cell division. That's a vulnerable stage in a cell history. We don't want to see that. And 50% of the women who said, I feel good, I think I found my dose, 50% were on dosages insufficient to support the long-term health of their vagina and their bones.
Yes.
And if it's too low for the vagina and bones, you can be certain that it's too low for the arteries and the brain and the skin and the mood and the energy and the immune system, on and on and on. So 24-hour urine hormone testing is imperative. I see no other that at this time that even comes close to the accuracy of it. And if you have intravaginal hormones, you can't test because the vagina is the urethra, the tube that goes from the bladder to the vagina, ends in the vagina. And so it's going to directly pick up, any urinary stream is going to directly pick up any hormones that are in the vagina.
Got it.
So if you freshly applied hormones, which is exactly what we want on a 24-hour urine hormone test, we want women to be taking these hormones consistently for a week, not missing a beat, getting it right, and of course through the urine collection period, right on through.
Right, but not vaginally. You're talking more about
if they're doing it vaginally, they're going to have hormones in their vagina, and a certain amount of those hormones are going to be washed right into the cup that you're peeing into directly. So you're not going to get a measure of what's in the body. You're going to get a measure of what's in the vagina. And I can tell you that happens for certain. And the levels are super high. It makes the test totally uninterpretable. So
I'm sure
there's another thing too. I mean, creams, gels that are applied to the vagina. What most women don't know about it is over 90% of what's in those creams and gels is not hormones. In fact, over 99% of what's in those toppy clicks or those syringes or however you're administering it of creams and gels, that's not hormones. Less than 1% is hormones. The rest of it is base, it's called, or vehicle, it's called. And it's a strong solvent needed to dissolve the ovarian hormones, get them into solution.
because they're heavy and fat and
well, they're insoluble. Like if you drop a drop of a hormone, an ovarian hormone, into water, it's going to float like your olive oil will on top of your vinegar.
Right.
It's not going to dissolve.
Right.
And so in order to get it up into solution so that every single dose that you click or you administer is the identical dose, you have to have it in solution. To do that by that method, you need a strong solvent to do it. So strong solvents day after day after day, no. I did the math once for a topical skin application of gels, and I was asking women to apply a quart of these gels to their skin every day. And at the same time, because I was always a functional medicine or a holistic medical doctor, I was asking them, most of them, to detoxify. Like, get rid of all your household chemicals that are unnecessary, which is 99% of them. Get yourself down to clear distilled vinegar and baking powder, baking soda, something like that. Yeah. Get it down to that. Stop using dry cleaners that use chemicals.
You can smell
Get rid of
them.
all your chemicals because you're getting, these chemicals are toxic. And you don't get exposed to your dry cleaning and keel over. No, they're not that strong, but they're strong and they add up molecule by molecule. And that's the problem with them. It's not like drinking a bottle of arsenic. Sorry for the image.
Right. There was a word that I learned called hormesis, and we don't need to go into that, but I found that pretty fascinating. But I don't want to go drink a bottle of arsenic.
Yeah.
Oftentimes,
but the herbicides and the pesticides in our food, they're very strong. I mean, what does it take to kill an insect or an herb? Strong chemicals. It's not fairy dust.
Yeah.
And this stuff adds up. So when my son and I discovered this over 15 years ago, that the hormones were in strong solvents, we went on to put together and patent. We have 2 patents on organic oils as a delivery system. So there's no solvents in there, which means you have to rotate the bottle before each use to mix it up into a suspension. That's very different. No solvents. So this is more to say that the creams and gels that you put in your vagina are in solvents. And I would never want to prescribe solvents on the skin and the vagina.
God, especially, yeah.
Yeah, anywhere, um, for a woman to do that day after day after day. And the final thing about the vagina, you could say, well, the vagina is a very good absorptive surface. Maybe by the time I go to test, it'll all be absorbed. No, we've done the testing on that too. We haven't worked beyond 60 hours, but for 60 hours prior to collection, those hormones are in your vagina. If you stopped your hormones 60 hours and then went and did the test collection, which you'd never want to do, the whole purpose of the 24-hour urine hormone test is to collect it while you're taking your hormones, so we see what hormones are in your body. But for other reasons, because of vaginal estrol, and I'm not going to go into it now, even if you were to stop your vaginal estrol 60 hours prior to doing the urine collection, you would find very elevated levels of estrol in the urine just coming straight out of the vagina. And this also includes the external perianal mucosa. Even that can drift into the vagina.
It makes
So
sense.
the deal is, don't apply it in your vagina. And I don't see any reason to either, because there's so many surfaces in your body. I mean, these hormones in the oils or even in the creams and gels, they absorb beautifully. We got 24-hour urine hormone testing. If a prescriber really knows their numbers, they really know how strong to make them, they can just give you the right milligrams per milliliter, and it's going to get into your body. If you apply it to your skin, it's going to get in there because it does very
Yeah,
readily and very reliably. So there's
and you
no
kind of
reason to
feel
put it
better.
in the vagina. Now, we do have a question that just popped up here that you see. What do you feel about dryness in the vagina? Well, sometimes vaginal dryness is from low estrogens, period. 100% of women who go into menopause, almost 100%, are going to get vaginal dryness. And the dryness is actually an indicator that there's vaginal atrophy. There's really change of the vaginal mucosa. It doesn't look like a young person's vagina. It looks very thin and fragile. And women who have this, they also have pain on intercourse. They're having intercourse. It's a very uncomfortable situation. And it also irritates the urethral meatus, which is where that tube that goes from bladder to vagina winds up in the vagina, and that can lead to chronic and recurrent bladder infections. So it's a big deal, vaginal dryness, and it happens almost 100% of the time without fail. It's a certain thing. And it takes a certain amount of estrogen. We know that number. We know the exact number. It takes a certain amount of estrogen making into your body to not have vaginal dryness, to restore the health or keep the health going of a vagina. And sometimes a younger woman who's having active intercourse has developed vaginal dryness in the perimenopause. Sometimes we will give a woman some vaginal estrogen for a while, a month or two before we test her. We'll also give her Biest, for example, to apply to her forearms. That's where we're going to rely on the major dose of the estrogens. But we can also apply the Biest or an estriol where we use the organic oils. Put a couple drops of the organic oils of the Biest or an estriol suspension onto your finger and place it in your vagina nightly. And that'll help accelerate the healing of the vagina. Excuse me. You will not have to do that for more than a month or two. If you just apply the estrogen to your forearms, for example, the vagina will heal, because when you apply it to your forearms, your general body estrogen levels are going to rise, and that's going to take care of your vagina. But for those of you who want to get a little extra jump start on the healing of the vagina, we do this rather frequently. I'd say 10 to 20% of the women who arrive in menopause who have vaginal atrophy, have dry vagina, have pain on intercourse, will suggest that they apply a drop or two of the Biest intravaginally every night until the vagina is obviously getting better.
What a blessing. Just getting better. I mean, because
Yes, exactly.
vaginal atrophy is no joke.
Yeah, exactly.
Ugh,
So,
so that getting better is so hopeful of a couple of words put together. Thank you very much.
and testosterone and DHEA also play into the health of the vagina. And sometimes when there's very significant vaginal issues, such as something called lichen planus erythrophicus, love the Latin there.
Oh, I thought that was Japanese. I'm sorry. Okay, it's Latin.
We'll also will sometimes add testosterone and DHEA to the intravaginal mix, and it's because they're also healthy for the vagina. But
Yeah,
usually the estriol or the biased will totally do it.
healing that vagina. I mean, along with everything else. But boy, I got to tell you, those are some hopeful words. Getting better, and we can get better. And thank you so much for offering that to us because a lot of women suffer from vaginal atrophy, and it is a very freaky thing to find out. I gotta
Mhm.
say, as a woman, like, oh, okay. Well, thank you. So moving on, um, I'm going to jump ahead a little bit because you just talked about this. A woman is taking estrogen via injections. The creams did not help. But the injections are not helping either. For whatever reason, she says, I cannot get my estrogen levels up no matter how I try. I've tested via blood because that's the only way my doctor tests. I've tested 3 different times at 3 different times. And each time my numbers vary just a little, but I still am totally suboptimal, very low end. I don't understand why this is. I'm wondering if you, Dr. Rosensweet, have ever run across this working with women in your practice, not being able to get estrogen levels up.
No,
Oh,
I've never, I've never run across it in my practice.
okay.
We've been
Well,
able to raise the estrogen levels of any woman, and all women are in menopause are low in estrogen, and we've been able to raise them universally always.
nice.
And sometimes, and I don't know what the situation is there. I know for men, and I am nowhere near expert in men, but I know that there's some men that they really benefit by injectable testosterone. And that's been going on for 50, 80 years. I don't even know the exact number. Men have been injecting testosterone. And I'm making a guess because I don't know the details there that either the prescriber hasn't made a specialty out of treating women in menopause with topical hormones, with topical estrogen and topical testosterone.
Right. She did make
Yeah,
mention of creams, but it's not
yeah.
really.
So they're using creams, but it takes a significant more knowledge to really know your milligrams per milliliter, your dosage strength, and you need to have a lot of experience to know when it's time to double or triple the strength. And I think many physicians, I'm making a wild guess here, I'm not saying her physician is, physicians are shy to use stronger dosages, but I never say never in medicine. And if injectable were the only route, it's getting in there. It's definitely getting in there. And if you can't tell by symptoms of excess or adequacy, if you inject estrogen, it's making it into your body. I can't even imagine how it wouldn't. And one of the ways that I would want to confirm that is by doing a 24-hour urine hormone test, because blood tests are tricky. Depends when you did the injection, and then when you drew the blood. How long after the injection did you draw the blood? Because estrogen levels are evanescent, it's known in the blood. That means they come and go because they're going into the tissue. And so I think with a little more diligence, topical estrogens could get your estrogen levels up. Never seen it not happen. And then as a fallback, there's nothing wrong with injectable estrogens. I prefer them to oral estrogens, actually. And the needles are so small these days that daily injection is not a big deal. I know it can be to some folks, but geez, I was born and bred on needles and syringes as a doctor. And once you get used to them, especially how wonderfully small these needles are these days. Woo!
Yes.
So injectable estrogen is going to work. And then it's just probably an issue of dosage is what I would declare. And again, here's what happens. Here's your estrogen level in your blood or in your body. You give an injection, bam, oops, wrong direction. Bam, that level goes way up. Injected, whoo, goes way up right away. And then it gradually declines. Well, when did you draw the blood? Did you catch it in decline? But 24-hour urine hormone testing takes care of all that. You just go ahead and do your daily injections and you collect that urine for 24 hours. And if you're injecting it, I'd be a monkey's uncle if those levels weren't detectable and measurable, and by increasing the dose, you could bring them into optimal range. We know what that optimal range is when you do 24-hour urine hormone testing.
Yes.
We know what too much and too little is. So if injection is the way, or I'm going to also assert that the cream strengths aren't being strong enough, or you're not applying it to the best absorptive surfaces in your body, which are usually the soft forearm right here. Soft right there. Skin absorbs really well near the wrist, between the wrist and the elbow, and the soft skin.
What about here, like on the deltoid?
Works. That's a very good place as well.
Okay.
There's a lot of soft skin in our body. So I'm going to say that some more research, and also you may have to connect with someone that they're specializing in treating women in menopause with hormones, because they're going to solve it.
Yep, you go on that journey, and eventually you will get there with the doctor. Yes. Okay. Well, thank you. I guess you keep on keeping on. And my famous.
The other thing I'd like to recommend is that someone draw a sex hormone binding globulin, SHBG, because hormone levels can be messed with if they're too high.
Right.
And the body knows how to protect itself, and it can really interfere with the dosage you're taking. I'm not saying that's the issue, but we always 100% of the time get a sex hormone binding globulin in the beginning of treating a woman in menopause.
Right. So
but you could get one now if you have an elevated sex hormone binding globulin. That could be interfering with the effectiveness.
Because
because it binds up too much of what you're taking.
Right. Is that dangerous?
No.
Okay.
Not dangerous. You just don't wind up with adequate hormone levels. But it's something that needs to be addressed. If you got an elevated sex hormone binding globulin, there's reasons why it got up there. And sometimes that's from overdose. And then what's really necessary is lowering that sex hormone binding globulin. It's going to interfere with the effectiveness.
Yes, and we've often spoken of that, and I've had my own experience with that. Interesting. I had no idea what that was some 3 years back when we met. Sex hormone binding globulin. The body's amazing. Huh?
The other thing about injecting is that I know it's common practice to inject. Well, I'm not going to say more about it. I'm going to leave it right there, actually.
Okay, well, this is going to help segue me into this particular question that came up. Can we please discuss how it is one would know if one should take DIM, endocarbonyl 3, or calcium D-glucarate?
Yes, these are curious. These are curious little names there. DIM is abbreviation. I think it's for diindolylmethane or something like that. And I3C is indole 3-carbinol. Those two are derivatives of the brassica family broccoli being the queen of the brassica family. And these are biochemicals that have the reputation of assisting in the metabolizing of hormones, especially estrogen. You know, your ovary puts out estrogen, or you're applying estrogen to your skin, gets into your body, circulates around the body, goes into the cells, goes into the cell nucleus, interacts with your genes. Holy mackerel.
Right, all that interconnectedness, huh?
Had its effect on that level of things. Who invented this? I'd like to know.
Well,
And then when it's done that interaction, it then circulated to the liver and it's biochemically transformed. So in the process of getting utilized, these hormones are biochemically transformed and excreted. So new hormones that your ovary produces or that you're applying to your skin can be operative. So your cells receive the hormones, they do their thing, then they're biochemically transformed and excreted from the body via the liver. And there's very specific biochemistry to do that. As a matter of fact, I just pull out this handy card here.
right.
And
Yeah.
that's some of the chemistry. And if you download Happy Healthy Hormones, that Carolyn's made available on the ins and outs of menopause.
At the very top of the page, just hint, hint.
we talk about that biochemistry, and young women have this biochemistry go a certain way. You know, the copy nature, the natural design, it has some specificity to it, and in some cases, the metabolization, the biochemical transformation, is not going according to Hoyle. In other words, it's not going like it's common for it to go.
Okay.
And the metabolic byproducts called metabolites, some of them are very friendly and some of them can be a little provocative. And the reputation is, although this is being debated, is whether the provocative metabolites, if they're too high, actually can be in the form of toxicity to the cells and even create a mutation and lead towards breast cancer.
Right.
This is debated. This is not a certainty.
Right, not set in
But
stone.
if you look at this handy little chart,
E2 to E1 down to, okay.
to 2-hydroxy or 16-alpha hydroxy,
Yes.
the preferred sweetest metabolite here is the 2-OH.
Okay.
And there should be, at least twice as much 2-OH as there's this 16-alpha. You need 16-alpha. You don't want 16-alpha, but you want about twice as much 2-OH as there is 16-alpha. And in some cases, you're producing too much 16-alpha and less of the 2. And this is where DIM and indole-3 carbinol come in. Their reputation is that they will reverse that adverse ratio and send it in the right direction. Having used DIM and I3C for 25 years and doing 24-hour urine hormone testing where I get to see whether it's doing that good thing or not, I haven't been very impressed. I'm uncertain about whether it's really doing it properly. And so I can't endorse them as enthusiastically as I have seen people endorse them. Now, I could be wrong, and I'd love for some of my esteemed colleagues to weigh in here. Dr. Bergson, Jim Hernser, if you're weigh in here on this one. And some people have accused this whole 2 to 16 thing has really come up because in medicine we like to do something.
Yeah.
We've got something, we want to do something. And so some have opined that this was all an invention of with profit motivation to be able to sell something. So I don't know. I don't want to go down that trail because I don't know what's so or not there.
Well, something that interested me is like, can a woman just like go into a health food store and buy DIM or endocarbonol 3 or even calcium D-glucarate? Like, can you just
Yeah,
walk in?
I'll get to calcium D-glucarate in a minute.
Thank you.
Yes, they can, and I'm not concerned about them. I don't feel like it would do any harm. And what they're purported to do is assist in the proper metabolism. Now, sometimes there are reasons why someone has more 16 alpha than they do 2. And this occurs in a woman who's being treated with hormones, and especially biased if there's too much estriol. It, by the law of chemical mass action, which you all know about because you hear about it every day, just kidding.
Hmm.
There's too much E3 there. The law of chemical mass action will mean that the 16 alpha will not convert to the E3 as well.
Right.
And the 16 alpha is going to build up and it's going to get higher than the 2. And even the estrone can build up. You don't need to know that level of detail. But the bottom line is if you've got too much 16 alpha, check first. And how are you going to find out? You're going to need to do a 24-hour urine hormone test. And I'm not going to rely on the urine 5 points for that or anything else. I'm going to say you're going to need a 24-hour urine hormone test. And if you see too much 16 alpha, here's what I think of. Number one, there's an excessive treatment with estriol. I love estriol. Every single prescription that goes out the door initially for every woman in menopause, we have 80% of the bias be estriol. But for some women, that's ideal. And other women, it's a little bit too much. And it'll cause an imbalance in the 16 alpha and the 2, in which case I will then adjust downward. I'll put less estriol as a percentage in bias. You asked for it, Carolyn Shapiro. The level of detail here is pretty thick. But
That devil in the detail. Yes, yes, yes. And it is thick. But
you
it's
asked the question. Now, here's the main thing I think of is I start wondering about a woman's liver.
ugh.
Because all this stuff is biochemically processed in the liver. And you're not going to pick up any liver challenges from 99.9% of the people by doing the standard liver blood tests. They're called liver function tests, but they're not function tests. They're liver illness tests. They're fabulous. Those blood tests, the SGOT, SGPT, ASOTs, etc. These are fabulous for detecting a sick liver, like hepatitis or something like that. But they're not good for liver function. How well is the liver functioning biochemically? You have to do something more sophisticated than that, because the liver might not be processing the estrogen that's been done its thing.
So
It might
that
not be processing it properly. So when I see imbalances in the 2:16 ratio, in other words, there's more 16 than there ought to be, or that's common in young women, I ask 2 questions. Does she have too much estriol, or does she have an unwell liver? Who's got a well liver at the midlife mark? Huh? Show
as I
me.
drink my cup of
Stand
coffee.
up. Stand up and raise your hand if you think you have a super healthy liver at midlife.
Well,
I've given this example many times on our Facebook Live. When I was in medical school, I made it through medical school with a strong will and a powerful commitment and coffee. Those 3 things.
right.
Because I would come home, eat dinner, and I'd have to study well
You
into
didn't have social media back then either. You had Grey's Anatomy and the Merck Manual, etc., etc.
heavy, expensive books.
Yes, I know.
And so about 11 o'clock, when I was seriously starting to fade, I would have to drink a cup of coffee to stay awake. And I'd drink that cup of coffee, and by goodness, I was ready to read the next. But about midnight, I started to fade again, so I'd have to drink another cup of coffee. And at 1 in the morning, and at 2 in the morning, and way too often at 3 in the morning, I'd have to have 5 cups of coffee to
I
keep
can't even
awake.
imagine. Oh
And
my
why did I need so many? Because my young liver was so healthy that it would get that extra caffeine, it would grind it up and biochemically process and excrete it so fast. It would occur at about the rate of once per hour. I'd have to refurbish. Now, I wouldn't dream of drinking a cup of coffee at dinner because my liver just wouldn't process it as quickly. As a matter of fact, it might keep me awake. May keep me awake if I drink a cup of coffee at dinner because my liver would be so much slower that it wouldn't get it done. So I think of the liver. I think of liver cleanses. When I think of the liver, I think of the gut. Why isn't the liver functioning? What kind of toxicity is being taken in? Is there any toxicity coming from the gut or from the diet? So these are detective challenges, and this information is readily available. And for those holistic and functional medicine physicians or nurse practitioners or health coaches that really go after this stuff, nutritionalist specialists, they understand this stuff. It's not the Greek that I'm putting it out to be. So you want to go on a liver healing program. That's where I go for. When I see an inappropriate amount of 16 alpha or an inappropriate amount of 4-hydroxy, I ask, how's that liver doing? Or is she on an overdose of estradiol? And then following and addressing liver issues is good for everybody. We all could use it. There's liver cleanses. There's healthy diets that help improve the liver. There's special diets that help the liver cleanse, and they all work and they're all good. You got to get rid of your household chemicals. You got to get your chemical intake way down. You got to move to organic. And every change that cup of, if you can't drink a cup of coffee at 6 o'clock at night, or if you walk into a mall and you have a real trouble tolerating it, or you can't stand people's perfumes, you got liver issues. Your liver's not processing these chemicals, and you want to go on one of these healing journeys that will lead you in the right direction in terms of nutrition, detoxification. It'll make you healthier if you follow the bouncing ball, and you don't have to do it overnight. And the final question is, what about calcium D glucarate?
Yeah.
Phase 1 of the liver, dealing with the hormones, is it converts these hormones. It changes them from estradiol and estrone into these metabolites, 2-hydroxy-16 alpha-4 estriol. And then it links up those metabolites with other chemicals. Glucuronic acid is one of them. Sulfates is another one. It binds those metabolized metabolites, those metabolites with something. It needs to bind it with something, and that makes it excretable. And calcium D-glucarate is one source of stuff you could take to help with the final step there, excretion. But I don't start with all these technical things called I3C and DIM until I ask, why is there something out of whack there? Why is that happening?
Right.
And it's usually the liver, and it could take us to the gut, and it could take you to a total household and dietary cleanup, and that'd be good for you.
All right. Get rid of that carpet. Get rid of that this and this and this and this and aerosol and all that stuff. Seems like a lot. It's
tiny question about DIM and I3C and calcium D-glucarate. It took us down into the deep waters once again.
But those deep waters are really interesting, and women, I'm telling you, write to me and they just want to know, and they want to know.
They want to know.
Boy, do they want to know. And you are so great at explaining it, to make it make sense to us. And I really appreciate that. We all do. you. Okay. Moving on to our next question. We have some good questions that came up here too, and we're actually a good time. So, we discussed this I think the last couple of interviews that we did, and that is that window of opportunity. Women are starting to really hone into this window of opportunity. Um, that is being discussed in regards to taking hormones. The questioner says, may we discuss the window of opportunity to take hormones? I have heard that there is a 10-year window only when you can take hormones. And it is confusing because I'm finding many women are starting hormones outside of this window. Are they effective if you do? It's confusing.
Okay, I've got a machine here that I'm going to activate. And if the vibrations get too intense, this is a very intense machine. But it is called a deconfusifier.
A deconfusifier.
Yes, it is a deconfusifier. And I'm going to activate this machine right now. Whoa, I have to turn this big handle here. Okay.
I just shot out of my seat, but I don't know if that was right, but whatever.
I told you it was powerful. It's good that you're holding on to your seat. You're buckled in there.
Yes, I am. I'm warned. Window of opportunity.
Thank you.
Yeah.
Thank you so
No problem.
Thank you, Carolyn.
Of course.
I've heard the window of opportunity applied technically to a couple different subjects.
Ah, interesting.
And here's the two subjects. One is that a woman should start hormones early and only take them for a prescribed amount of time. And if she doesn't take them in that amount of time, you might as well not even take them.
Ooh.
That's one thing that
Okay.
I've seen confused as the window of opportunity. The other thing relates to if you go too long without taking hormones when you're in menopause, you've gone through your window of opportunity and you shouldn't take them because there's special risks involved.
Right.
So let me both of them can be covered by the same answer as the deconfusifier is spitting it out on ticker tape. So I'll just read it as it comes out here. Look at that. It's clear as a bell. I'm actually a robot, and the deconfusifier just operates.
I didn't want to say anything.
Okay. We've been revealed.
We have, and it's okay. People seem to enjoy it still.
All this came about, or most of this came about in 2002. For that fateful day. Because prior to 2002, and for 1,000 years prior to 2002, women were being given hormones in menopause.
Right.
And we're most familiar with the last 50 years prior to 2002, I don't know the exact number, when Premarin and Prempro, horse urine-derived estrogens, and also coupled with a molecule called a progestin, 18 million American women were on these hormones. That's 40% of the women in menopause. And nary a squeak was heard to speak of.
Nary a squeak was heard. I love that.
And when you see women who were on those hormones, what I saw as a physician is benefit. They benefited. And they liked those hormones, a lot of those women, and they were on them for their lives, their whole lives, many of them. Now, in 2002, a false medical study was published. It was false. It asserted that there was an increased risk of breast cancer with one of the two products called Prempro.
Yeah.
And however, it was false because even in that original study published, it said that increased risk was statistically What that means in medical and statistical terms is there that never should have been published because it did not state an increased risk medically. But it was published. Most crazy misogynistic event that's taken place widespread in my lifetime because it damaged women. And those 18 million women, boy, so many of them, they went down to the low millions, went off of those hormones with plenty of consequences.
Mm-hmm.
But I mean, low millions. And then only by 2016 had the numbers increased. They had only increased to about 5 million. And over half of those women were on compounded bioidentical hormones. So that was the body blow that took place in 2002. When I originally saw that study, I went, wait a minute, this is statistically insignificant. These things are not increasing the risk.
Right.
We have no proof of that. European literature showed bioidenticals did not increase the risk, showed less risk. The Premarin even was at less risk. I kept on treating. By 2006, that study committee knew that there was no increased relative risk. And by 2000, they published that, and we saw that. Nobody heard of that. And by 2017, the original Women's Health Initiative Study Committee published in the original Journal of American Medical Association, that after 18 years of follow-up, there was no increased risk of breast cancer, heart attack, and stroke. Was no increased risk. But who's heard of that? Some, but very few still, relatively very few.
That fear is huge.
That fear is huge, it's pervasive, and it's incorrect. Now, that's not to say that we're not at risk for thousands of diagnoses. As a man, well, I'm sorry, and we're also at risk for hundreds of cancers, men and women. And as a male, I'm in a special and increased risk for prostate cancer. There's reasons for that. Modern day reasons for that. And women are at increased risk for breast cancer, uterine cancer, and ovarian cancer. And there's reasons for that. However, women who are treated with hormones, even Premarin and Prempro, are at less risk for breast cancer, heart attack, and stroke than women who go untreated.
It takes a while for that to sink in, but you say it every interview.
I like to say it frequently.
Yep.
Now, back to 2002. Massive millions and millions of women went off these hormones.
Right.
And millions of them experienced why they went on hormones in the first place. They got disabled. They couldn't sleep. Their mood tanked. Their ability to think clearly really diminished. They lost their libido. They started developing hot flashes in the middle of the night, hot flashes during the day. Their whole lives were disrupted. 75% of women who go into menopause have raucous, life-disturbing symptoms. And so something had to be done. So the suggestion was made that seemed to be the practice, the way people practice. It wasn't based on anything. Well, take the lowest dose that you can for the shortest period of time. And the sooner you get to it as you're going into menopause, the better. That's one way I think of the window of opportunity. Take the lowest, it wasn't based on anything, but, out of desperation, out comes this suggestion to take the lowest dose for the shortest period of time, and that's what I'm referring to as the window of opportunity. Shortest period of time. Incorrect, retracted by the original study committee in 2017. It's no longer written medical suggestion, but you have to be a specialist in the field, or you have to be really on top of the field to realize that that's been rescinded. That's no longer being the recommendations. Now so that's one thing. Okay, if you got to take hormones, be afraid and take them for the shortest period of time in the smallest doses possible. And the shortest period of time is a window of opportunity. Do so as early into menopause as you possibly can. That's one thing. Now I want to go to another window of opportunity. Estrogen is so protective to the coronary arteries. So much so that the incidence of coronary artery disease and heart attack is much lower in a woman than it is in a young man, young woman, young man. You hardly ever hear of a woman having a heart attack when she's young.
Right.
But occasionally you hear about a man in his 40s, never sick a day in his life, keeled over on the tennis court and figured, died from a heart attack. It's not common, but it happens. However, that incidence equalizes by the age of 60. Men and women have the same rate of coronary artery disease and heart attack, and the difference is estrogen. So the window of opportunity is women get treated with estrogen while it can still make a difference to your coronary arteries, because heart attack and stroke, well, 50% of us leave the planet Earth eventually from a heart attack or stroke. It's a big deal. So if you don't get treated within the first 10 years, you're at risk. Your arteries lost that protection of the estrogen. So you better get treated, and if you don't, you're done for. The window of opportunity, get treated, or your coronary arteries can be so adversely affected in those first 10 years that you could be in trouble. This is relatively new on the horizon, this particular understanding, this particular suggestion.
Yeah.
Window of opportunity. You better be treated within the first 10 years, and if you're not, maybe you shouldn't even be treated, because
Right.
there is an incidence of this. If you have coronary artery disease, arteriosclerosis, the inside of that artery looks like a boat bottom that's been in the sea for a while. It's got barnacles on it. These are atherosclerotic plaques, look like something. In fact, on autopsy, and you look at someone's coronary arteries that has atherosclerosis, you don't see a nice, smooth arterial surface. You see something that looks like it's got these barnacles on it. And these barnacles are a perfect catch point for a clot. They will provoke a clot. So when you hear someone die of a heart attack, they don't die of the atherosclerosis. The atherosclerosis does not choke off the arteries. In fact, you can form ancillary arteries, collateral arteries, that make up for the arteries that are slowly getting a narrow diameter and not providing sufficient circulation. It's the clot, as emphasized by that sound of a car taking off. It sounded like to me.
It was, and it was highly obnoxious, but I can't find them. They're
No, it was.
long gone.
We created that to underscore that it's the clot. Or I was walking through a seminar, a holistic medical seminar, many years ago, and I had just been zeroing in on coronary artery disease, and I walked up to someone I knew, Gary Gordon, a medical doctor, a pioneer in this work. God bless Gary Gordon. And I walked up to Gary Gordon excitedly, and I said, Gary, look at this lab test I've got on someone who's got elevated homocysteine and elevated C-reactive, highly sensitive C-reactive protein, and they probably have coronary artery disease, right? I detected it. And he said, well, you don't know, but here's the thing about coronary artery disease. It's the clot, stupid, is what he told me.
I didn't want to say anything again.
What he was pointing out, that it's not the arteriosclerosis that specifically takes out someone in a heart attack. It's the clot that forms on that roughened arterial surface, because roughened arterial surface provoke coagulation.
Yes.
So, and he promptly walked me over to a coagulation laboratory to say, talk to these people, they know how to assess coagulation. And there's a method in my madness here. I'm going to refer back to this. So if a woman has gone 10 years without estrogen, she's at risk for a clot being in that coronary artery.
Yikes.
And for 1 year, and this is really mystical, if you treat her with estrogens, it enhances in a statistical way the chance of that clot breaking loose and her actually having a heart attack.
Ouch.
Look at the emphasis we're getting. Now we
Yeah,
get a siren to underscore that. It's fantastic. We're in cooperation with Los Angeles. It's fantastic.
I got a megaphone out there. Yep.
Yeah, Daryl wired us in
He
with a
didn't put
sound
us right
system
on the roof.
to get street sounds to
Sorry.
underscore what we're doing.
You're just not hearing the wild animals. You know, you had me way back in the day. You explained this to me. And I did see a cardiologist just to get checked out to make sure I was okay. I'd been many years without hormones for myself. Is that a good idea to do?
Yeah, so here's the bottom line. When a woman has been 10 years without hormones, and we're taking her initial case history, which we do in a very, very elaborate questionnaire along with some laboratory tests, and we see she's been without 10 years without hormones, we will often, prior to prescribing hormones, because of this window of opportunity issue, ask her to get a stress echocardiogram with her cardiologist, or at least have her cardiologist evaluate her coronary arteries.
Right.
I love stress echo for a woman because it's the least invasive. And it tells us whether there's compromised circulation in the coronary arteries in a non-invasive way. Now, when Jim Hertzler and I were discussing this brilliant genius pharmacist
Oh, he's
outside
amazing.
of Dallas who knows a tremendous amount about treating with hormones, we realized how many people we treated over the many, many years before we'd even heard of this propensity for embolus. And we realized we treated hundreds and hundreds of women, many of whom had very high risk for coronary arteries, had diabetes, who were overweight, very high risk, and we didn't have any of these adverse events. So it's a real choice on the part of the original prescriber as to whether or not evaluating those coronary arteries is important. And to me, it has been important. And there's two evaluations that I want to do, one or both. And the other one is a coagulation study. But that's for other reasons. And we definitely covered this in great detail in our professional training program that we have online for healthcare professionals, doctors, nurse practitioners, prescribing, compounding pharmacists. So what's the bottom line here? If you're 10 years without hormones, you want to go to someone who really knows what they're doing and should make that call about whether you should get, if to cover all bases, an evaluation of your coronary arteries by a cardiologist or at least by a stress echocardiogram. And I do that. I do it about in 75% of the women who've been without hormones for 10 years. I'm still doing that. I want to know. Why? Because I think being rigorous is a good idea. Because
I
I
think
don't
you're
want to
right.
look
Yeah.
back and say, oh, I forgot to do that on somebody. And they actually were one of those people. Now, I'm not here to alarm you because of what Jim Hertzler and I were, talking to each other about of how many hundreds and hundreds of patients we treated who were at huge risk because of 10 years out. Now, do we adhere to the 10-year window of opportunity? No, we don't. What we do is 7 years, 5 years, we evaluate each individual woman. If she's been without hormones for 3 years or 5 years, we're curious. And we may do it as early as that. And then the other issue is because medicine's got a complexity to it that's rather staggering. And when it comes down to it, it's always a risk-benefit analysis. And just to give you an idea, my 86-year-old mother-in-law at the time, who's now deceased, bless her heart, loved her so much.
Mm-hmm.
A note right on my desk here from her.
Aw.
She had 3 heart attacks and 3 coronary bypass operations.
And how old was she?
Well, this was in her late 80s. She had already had 3 operations. and she fell and fractured her pelvis and her humerus. That's her upper arm bone, clavicle, and it was 3 months in rehab. And when she got out of rehab, she was super low in hormones. Of course, she hadn't taken any hormones from her total hysterectomy in her mid-30s. Hadn't taken any hormones. And risk benefit, I just treated her. And we have a video, and I saw that video yesterday as I was reviewing for an educational presentation of her sitting on a low couch, arms up in the air, standing up without the use of her hands, and this big, huge smile on her blessed face. So you never say never. These are always individual things. Sometimes you take the risk because it's a risk in not treating with the hormones. And I treated my my mother in her late 80s. They were both in their late 80s. They were friends.
Aw.
Yeah, definitely. And my mother once called Mary her best friend.
She just didn't like you treating her. That's all.
Yes. My mother was getting cognitive challenges, and I went ahead and treated her with estrogen. There was no way I was going to get her to get an echo stress test.
Yeah.
No, it was not going to happen.
Yeah, right.
So we went ahead and treated her. And so you never say never. It's always about the individual patient. Always. You always evaluate the individual patient.
Yeah.
So there's nothing especially specific about a 10-year window of opportunity. I've gotten stress echoes on women that were 5 years out because they had special risk factors, and there's ways to evaluate those other risk factors. So, oh my God, look at the time.
Yeah, it did fly. I do see that I believe that you put up that in regards to Jahira. I hope I'm pronouncing your name right. I see everybody's questions. I will get to them. I did my best to get to all the other ones that we had from last week. And we will go ahead and we'll sign out. I'll get busy working on this because we're going to be back here again on Thursday. Yeah?
Yeah.
Okay. So I guess for today,
So,
it's a wrap.
hasta la vista.
Yeah. Hasta la vista. Au revoir. A plus tard. All of that. Again, Latin, right? Have a great day, Dr. Dear David Rosensweet. Thank you, ladies, for coming up. And we will see everybody on Thursday. Okay?
All righty then. Bye-bye,
All right.
everybody.
Bye, you guys. Bye, Dr. R.